Welcome to this explainer, colleagues. Grab a seat. Today, we're stepping into a true clinical masterclass. We are going to peel back the incredibly complex layers of borderline personality disorder, or BPD. For literally decades, this diagnosis carried such a heavy stigma. It was often seen as this completely intractable condition. But today, we're going to completely transform how we view and treat these patients in our daily clinical practice by diving into the absolute latest neurobiological and psychodynamic data. Here's our roadmap for today's explainer. We'll be covering recognizing the borderline patient, etiology and childhood trauma, the neurobiology of hypervigilance, splitting and mentalization deficits, psychotherapeutic treatment models, and finally, essential clinical skills. All right, let's jump right into section 1, recognizing the borderline patient and moving beyond that old life sentence myth. When we're actually sitting across from these patients in the room, we've got to ground ourselves in diagnostic reality first. We have to completely discard this outdated, pessimistic notion that BPD is some untreatable, lifelong sentence. Just look at the history of the diagnosis from the 1930s all the way to the DSM-5. You can actually see how the psychiatric field finally wrangled what was once considered a really messy syndrome into a rigorous, well-defined diagnostic entity. Early on, it was called pseudoneurotic schizophrenia because, the patient seemed to occupy this weird in-between state. But researchers like Grinker and Gunderson proved that these patients do not actually deteriorate into frank schizophrenia over time. Instead, they are what we call stably unstable, which gives us a very distinct, recognizable syndrome to work with. So what does this actually look like for us? The crucial takeaway here is that these core DSM-5 criteria manifest right there in your consulting room as an overwhelming, almost desperate demand for exclusive attachment. When our patients get close to someone, this incredibly intense set of twin anxieties gets triggered. On one hand, they are terrified of engulfment, basically losing their identity in a primitive merger fantasy. But on the other hand, they experience sheer absolute panic that they're about to be abruptly abandoned. Now, this is fascinating. Notice the really stark gender divide in clinical populations, a 72% female to 28% male split. But colleagues, we need to be really careful here. Male borderline patients often present quite differently. They are way more likely to have substance abuse issues, and honestly, they're frequently mislabeled as having antisocial personality disorder. This means a hugely significant portion of men with BPD are just flying completely under our diagnostic radar. And as clinicians, we must remember, and absolutely share, this incredibly hopeful piece of data. Prospective long-range follow-up studies show us that 85% of BPD patients actually remit over a 10-year course. 85%. That means the acute symptoms of emotional dysregulation, self-harm, and impulsivity will naturally subside, even without lifelong treatment. BPD is literally not a life sentence. However, we have to balance that incredible hope with this serious clinical risk. The suicide rate for BPD sits between 3 to 5%. That's a number that requires our absolute utmost vigilance. We have to carefully manage what we call coercive bondage. That's when the patient omnipotently controls the therapist through suicide threats. It forces us into these frantic, heroic rescue measures instead of doing actual effective psychotherapy. Moving on to section 2, etiology and childhood trauma, the genesis of the disorder. The developmental data here tells a very stark, deeply traumatic story. Early psychodynamic theories love to blame maternal overinvolvement. But the reality? 82% of patients report childhood neglect, and roughly 60% report childhood sexual abuse. It's profoundly sad. That severe neglect and abuse completely shatters the child's ability to form secure attachments. They just never develop the internal working models they need to understand and trust the intentions of the people around them. Let's dive into section 3, the neurobiology of hypervigilance. Let's look at the actual hardware of BPD. This is where the neurobiology gets incredibly interesting. Our BPD patients actually have this highly accurate, survival-based radar for detecting emotion. They can spot a microshift in a facial expression way faster than healthy controls. But, and this is a massive but, their hyperactive amygdalas cause a huge problem with interpretation. They massively overreact to ambiguity. They'll look at completely neutral faces and interpret them as malevolent, untrustworthy, and threatening. This perfectly explains those sudden, jarring transference misreadings we experience in our sessions when we're just sitting there with a completely neutral look on our face. Looking at these brain mappings, the pieces really fall into place. We see exactly why our patients cannot just simply shut down their negative emotions. Under emotional stress, the ventromedial prefrontal cortex in a BPD patient shows dramatically decreased activity. Its inhibitory function is simply too weak to counteract the severe, trauma-primed hyperreactivity of the amygdala. They are quite literally trapped in a massive limbic storm without any prefrontal anchor to hold them down. Now here's a true game changer, an actual, literal deficit in endogenous opioids. RBD patients aren't just being dramatic or attention-seeking, right? Their emotional pain genuinely feels like excruciating physical agony because they literally lack the biological soothing agents that the rest of us just take for granted. This completely explains why they might self-mutilate. Cutting actually releases those necessary endogenous opioids to chemically self-soothe. It's a biological survival mechanism. Okay, Section 4, splitting and mentalization deficits. Let's visualize these internal dynamics. This visual map is absolutely vital, especially for our trainees. It brilliantly illustrates how the patient internalizes their early trauma. You have this victimized self linked by intense hypervigilance and anxiety to a persecuting object. And in therapy, well, the patient routinely projects that bad persecuting object right onto you, the therapist. This is what creates that relentless, exhausting cycle of hypervigilance and accusation right there in your consulting room. Because of this profound identity diffusion, the patient simply cannot integrate positive and negative qualities in a single person. They actively use splitting. They separate everyone in their environment into absolute extremes. One day, you are the omnipotent savior. The next day, you are completely malevolent and corrupt. To them, we are, as Otto Kernberg famously noted, either gods or devils. There's absolutely no middle ground. Consider this wild anecdote from the literature regarding what we call the psychic equivalence mode. A patient erupted in total rage, 100% convinced her therapist hated her just because he briefly glanced at the clock. When he tried to offer a different, more benign perspective, she slammed her hand down and yelled, "I saw what I saw. It's like you're telling me that this table is not made out of wood." In psychic equivalence, their subjective perceptions are treated as absolute, undeniable physical facts. It's as real as the furniture to them. So what do? Our primary clinical job is to bridge that enormous gap. We absolutely have to help the patient shift out of that rigid psychic equivalence and develop mentalization. Mentalization is essentially the capacity to step back and reflect on the internal minds of themselves and others. It's the realization that our thoughts and feelings are just subjective representations of reality, not absolute, concrete facts. Moving right along to Section 5, psychotherapeutic treatment models, specifically looking at our evidence-based frameworks. The fantastic news is that we now have several highly efficacious evidence-based treatments at our disposal. Whether you are using MBT to enhance reflective functioning, TFP to interpret negative transference, DBT for emotional regulation, DDP for interpersonal encounters, or GPM for practical case management, the data is incredibly promising. But why do all these wildly different models work? Well, it's because providing a systematic conceptual framework that finally makes sense of their internal chaos combined with maintaining a strong, consistent therapeutic alliance absolutely works to heal the borderline mind. It's a real game changer. And finally, Section 6, essential clinical skills, or as I like to call it, surviving the room. When you're actually in the thick of it, managing the encounter means you must direct their attention away from those limbic emotional storms and toward prefrontal reflection. How? By flexibly establishing strict boundaries. You have to enforce conditions, but without malice. Please do not become the punishing parent. And most importantly, you must always look past the vitriol to empathize with the deep, opioid-deficient pain that's lurking right beneath their narcissistic rage. As therapists, we absolutely must normalize our own struggles here too. You have to continuously, rigorously monitor your own intense countertransference. The sheer hatred and panic these patients project can so easily coerce you into boundary violations that are cleverly disguised as heroic rescue attempts. Seriously, consult with your colleagues, lean on your supervision, do whatever it takes to ensure you don't fall into that trap of coercive bondage. As we wrap up this masterclass explainer, I want to leave you with this ultimate clinical challenge. When the patient inevitably projects their trauma onto you and transforms you into the bad object, can you function as a secure container? Can you refuse to retaliate, hold their projected pain, and maintain your own capacity to think clearly until they are finally ready to own their feelings themselves? It's tough, but it's exactly what they need. Thank you so much for joining me, colleagues.